Hello everyone, this is Yonis. I am an emergency medicine doctor. I would like to talk to you today about surgical chest drain insertion. Chest drain is a tube which is inserted through the chest wall between the ribs, reaching to the pleural cavity. It's often needed when immediate action is required. So, the process of insertion of chest drain is a life-saving process or procedure. However, it requires sterility, analgesia, and proper technique with safety. The indications for chest drain insertion are pneumothorax, which is either primary, secondary, or complex pneumothorax. Here we have the tension, bilateral, recurrent, persistent pneumothorax, also pneumothorax and positive pressure ventilation. The British Thoracic Society made a very nice diagram or pathway for management of pneumothorax. They divided the pneumothorax into either primary or secondary. So the primary pneumothorax happens in young people, tall and thin, and males more than females, familiar, and people or patients will be smokers. They tend to have this type of condition. And secondary pneumothorax, older patients, pre-existing lung problems, high incidence of respiratory failure, and with a high mortality. So if we have a look to the diagram, in the primary pneumothorax, when we do the chest X-ray, we will see if the size of pneumothorax is more than centimeter or the patient is breathless. We will go to the aspiration. So that we will aspirate by inserting the 16 to 18 gauge cannula. And then after that, we will see if the patient became better and the process or the procedure was successful. We will discharge the patient and we'll ask them to come back to the outpatient department. However, if the process wasn't successful, we will go ahead to the chest drain insertion. If the size of pneumothorax is less than 2 and the patient is stable, normal saturation, so we can discharge the patient and ask him to come back in 2 to 4 weeks to the outpatient department, respiratory clinic. In the secondary pneumothorax, the pathway is a little bit different. So we can see here, if the size is more than 2 centimeter or breathless, we will go straight away to the chest drain insertion. While if the size between 1 and 2 and the patient is breathless, so we will do we will aspirate by using the 16 to 18 cannula, gauge cannula. If the process was successful, we will admit the patient. If the process wasn't successful, we will do chest drain insertion. However, if the size is between 1 and 2 centimeter, and the patient is not breathless, so we can admit under observation with high flow oxygen. So this is the pathway here. Other indication for chest drain insertion is hemothorax, when there is blood in the pleural cavity as a result of trauma, for example. Any chest trauma complication. So we can see here, when there is multiple rib fractures, this what will lead to flyer chest. Flyer chest is a life-threatening condition that requires an immediate action. So we can see here in this video, this is the flyer chest. So you can see the movement of the chest wall. So this is classical, and you can see the ecchymosis, which means that this is the site of the trauma. Large symptomatic pleural effusion. In the large symptomatic pleural effusion, ultrasound guided chest drain insertion is required. Also, empyema thoracica, which is the collection of pus in the pleural cavity, we will need to have a wide bore chest drain. Chylothorax. In chylothorax, this is actually this is one of the conditions that require the chest drain insertion. Chylothorax, it's a rare condition actually. resulting from thoracic duct damage with chyle leakage from the lymphatic system into the pleural space, usually on the right side, right chest. It has multiple etiologies and usually discovered after it manifests itself as pleural effusion. So this also requires chest drain insertion. Also, another condition, we call it esophageal rupture condition. It's ruptures of the esophagus can be caused by surgical procedures, severe vomiting, or swallowing of a large piece of food that becomes stuck in the esophagus. But some of them happened spontaneously. So we can see here in the chest X-ray, you can see two things. There is pleural effusion because of the rupture of esophagus, and we can see here pneumothorax as well, sometimes pneumomediastinum. So these are the conditions, these are the indications for chest drain insertions. Contraindications, the most important contraindications, bleeding disorder and coagulopathy. We have to make sure that the patient is not having any coagulopathy and or bleeding disorder, or is not on medications. If the patient is like blood thinning medication, which is anticoagulation or antiplatelets, we have to reverse them before the insertion of chest drain. The procedure should be consented with the patient or the next of kin according to the trust guidelines. So the equipments we need for chest drain insertion: sterilized chest drain tray, local anesthetic, lignocaine, sterile gown, mask, gloves, drapes, 2% chlorhexidine or antiseptic iodine, gauze, syringes, different sizes of needles, scalpel, size 11 blade. This is what I really like. Sometimes they go with size 15. Pair of scissors, Kelly curved clamps or artery forceps, Robert artery forceps, needle holder, chest tube clamp, and tooth forceps, non-absorbable suture, size 1 or more. So here is the tray for chest drain insertion. Also in the equipment we will do the chest tube without trocar, connecting tube with a sterile drainage system, and gauze for dressing. So here are the chest drain, these are the underwater seal. We can see them here. The chest tube is the chest tube sized according to the diameter, marked with numbers. These numbers are important. So when we do handover, we have to mention to the to whoever takes a handover that the chest drain was inserted to this number. So if there is sometimes if the chest drain starts to slide out, they need to know exactly which number we put the chest drain in. Several drainage holes, they are on its end of the chest drain, which are important. We have to keep them in our mind that they should be inside the chest cavity, and radio-opaque line through the tube. So here we can see that this is the radio-opaque line. This line is important. When we do the chest X-ray, this will show exactly where is the chest drain, and these are the holes. They need to be inside the chest cavity. Choosing the size of the chest tube. What is the right size of the chest tube? So size 16 French for children with pneumothorax, and size 24 to 28 French for chronic lung disease and patients with traumatic pneumothorax, and size 28 to 32 for viscous fluid hemothorax, empyema thoracica, or to evacuate pneumothorax in a patient with mechanical ventilation. So you can see here the different sizes. So infant and young children, they will go to small sizes, while the adult will go higher up, and if there is like thick viscous fluid, requires more sizes. Before starting the chest drain insertion, what are the things that we have to do is, first of all, check the chest x-ray. This is really important. I normally check the chest x-ray 3 or 4 times before inserting the chest drain, because I need to know exactly where is it, and I need to know how can I perform it in a proper way. Also, before starting, you have to consent the patient. You have to do the checklist as well. These are really important. You have to say everything, to tell the patient everything about the procedure, what are the possible complications, what are the possible outcomes of the procedure. If the patient has dementia, for example, or somebody is the next of kin, who is next of kin, you have to mention this one to them in order to make sure that you cover the requirements for chest drain insertion. Positioning of the patient. So supine or semi-recumbent position, these are the different positions for chest drain insertion. So before inserting the chest drain, there should be we have to know the anatomical considerations. What we call it triangle of safety. So the triangle of safety is the triangle that we are through which we are going to insert the chest drain, and it is the safe triangle. It is bounded by the lateral border of the pectoralis major muscle, anterior border. So this is the lateral border of pectoralis major muscle, anterior border of latissimus dorsi muscle, and the apex of the triangle is in the axilla, and the inferior border of the triangle formed by a horizontal line passes through the nipple inferiorly. This is the inferior border. So this is what we call it the triangle of safety. Also, we have to mention that the insertion will be anterior to the mid-axillary line. Okay. Technical preparation: prepare the set, occlude the proximal end of the chest tube with the chest tube clamp or forceps. Here we can see that one, how to occlude it. The reason for that is that when we occlude the one of the ends which goes inside the chest drain, this will guide us when we are putting the chest drain inside, when we insert the chest drain. And this clamp, the other clamp, sometimes it's important when there is pneumothorax, because when you insert the chest drain, you have to make sure that this clamp is closed, because there will be a gush of blood coming out to you. So this is how it should be. By using Robert forceps, grab the distal end of the tube. This will aid in passing the tube within the tract. The procedure: mark and clean the area, cover the field, select the intercostal space, stay over the rib below. Here we go. That this is the intercostal space. We can see here this is the rib, and this is the other rib, and we can see that the intercostal space here, you can see these are the neurovascular bundle, subcostal neurovascular bundle, VAN, vein, artery and nerve, intercostal vein, artery and nerve, and these so when we insert the chest drain, it should be over the rib and goes to the like over the rib, goes straight away over the rib, goes to the superior border, to the rib, far away from the neurovascular bundle. In the triangle of safety, anterior to the mid-axillary line, this is the triangle of safety. Okay, so it should be, this is the mid-axillary line, it should be in this position. Lignocaine, 1%, the dose is 10 milligram per mil, and we have to give the dose which is 3 milligrams per kg. We will insert first 0.5 ml of local anesthetic by a small gauge needle to make a wheel for the insertion of the large needle. By using larger needle, also we will insert the wheel, through the wheel we will go infiltrate the skin and layer by layer by the correct dose of local anesthetic. Pass the needle over the superior border of the rib below to reach the outside of the pleura, of the parietal pleura, and inject the local anesthetic. So be generous when you insert local anesthetic for the chest drain insertion. However, you have to keep the right dose for every single patient. This is really important. So you can see here, this is the insertion of the needle. So this is the intercostal space. You can see we put the needle over the rib, passing it to the pleural cavity, and we insert the we inject the local anesthetic. Intercostal muscle layers. Here we can see that there are 3 layers of intercostal muscles. So the first layer is the external intercostal. So on both sides it shows like V shape, like appearance. And the other layer, which is the internal intercostal muscle layer, it goes the inverted V shape. And the third layer, which is the deepest one, it is the innermost intercostal layer. So this gives us an idea how to orientate our retractor and forceps while we are inserting the chest drain. 1.5 centimeter to 3 centimeters insertion over and parallel to the rib. Through the wound, use the curved mosquito forceps or Kelly to do blunt incision, reaching the intercostal muscle. So here, this is how it goes. Actually, you can see that this is the forceps. You can see. Just do it in this way and separate the muscle layers. Okay. Now use the index finger to dilate the tract. Okay. Also, after that, once reach the pleura, push the curved artery forceps or Kelly clamp through the pleura. You will feel a give or a sudden release of a resistance. So here we do it this way, and you can see the sudden release of the resistance. Now we are inside the pleural cavity. Inside the pleural space, rotate your index finger in 36 degrees. This is actually important step, because this will release if there is any adhesions around the entrance to the pleura. Pass the tube through the intercostal space when unclamped. The Roberts forceps or Kelly clamp push the tube through the tract slowly, using the index finger as a guide. Okay, so here we can see that just mounting the tube with the forceps while you are pushing it. So this is the way how it goes, and then insert it. That's it. Misting in pneumothorax, blood or fluid in pleural effusion or hemothorax, you will see them as these are the signs of the chest drain, the right chest drain insertion. Also, you can check if there is any air or collection of air around the chest drain insertion, which is an indication of the subcutaneous surgical emphysema, which means that the chest drain is not in the right position. Push the tube in the apex in case of to the apex in the case of pneumothorax, or you can push it to the base in pleural effusion or hemothorax. So we can see here, but after the insertion of chest drain, this is how it goes, and push it, that's it. So this is the way how it goes, and then you push the chest drain. Okay. Identify the numerical markings, as we said before, of the tube, making sure that the holes of the tube are all inside the pleural cavity, which are important in handover to make sure that the tube is not falling. Connect the tube to underwater seal system before unclamping, and keep underwater seal at least 1 centimeter below the patient. So here, after connecting, we just opening the clamp so everything will get out from the chest. Right. This is also important actually when you keep underwater seal 10 centimeter below the patient, especially when the patient is moving. When they move the patient or transmitting the patient to other ward, we have to make sure that the underwater seal is underneath the patient. Secure the chest drain by simple or interrupted mattress suture. Here we go. The thing is, you have to make sure that it is feasible for the for other colleagues when they are removing the chest drain, so they can close it properly. Right. Apply the gauze and dressing. Make sure that you can see the chest drain entering the chest. Re-X-ray after that. This is really important. You have to make sure that the chest drain is in right position, is not kinked inside. These are really important steps to be done. Do not advance the chest drain if it is not in position. So if you see that the chest drain is not in position, do not advance it. You have to do another one. You can pull it if the chest drain is deep in the chest cavity, thoracic cavity, but if it is not deep, you cannot advance it after the procedure. Here is the step of real chest drain insertion. We can see that, and after anesthesia with lignocaine, the level of the rib. This is the local anesthetic, and then after that you can see we inserted the needle deeper and deeper and deeper to the area, and then insert between the ribs as well to provide a good cover of the local anesthetic. Now we cut the skin parallel to the rib and dilate the wound with the surgical clamp. And we'll go straight away to the pleural membrane. You can see that the give, and you can see how you can see the give happened, and you can see how to dilate. So you go out and dilate, and then put your finger inside and also dilate again. You guide it and insert the chest drain. Okay, clamp it and you direct it after that. So either to the upper chest or lower chest, and then after that you will do the suturing. Now this process should be done, and you can see that we are just tidying the chest drain, and we connect it to the underwater seal. That's it. Okay. Here is the procedure, and these are the steps of the procedure, how they look like. Complications of chest drain insertion: bleeding, hemothorax, traumatic perforation to the lung, heart chambers, diaphragm, or intra-abdominal organs, intercostal neuralgia due to the trauma to the intercostal bundle. This is also one of the complications. Injury to the long thoracic nerve that causes winched scapula, because this will lead to the paralysis of serratus anterior muscle. Tube blockage by clot or debris, you have to clean it. And subcutaneous surgical emphysema, as I said to you before. This should be assessed as soon as you put the chest drain. So when you put the chest drain, while we are waiting for the chest x-ray to be done, you have to assess if there is surgical emphysema, because surgical emphysema is easy to be diagnosed. Re-expansion pneumopulmonary edema due to drainage of more than 1 liter of fluid in less than 30 minutes. So you have to make sure that you are controlling the drainage of fluid from the chest cavity after inserting the chest drain. Infection of the drain site, this will lead to empyema, malposition, and then fall of the tube. Alright, so here is the summary. The summary is that the chest drain insertion is a simple procedure, life-saving procedure, and it requires a proper training, and it needs to be done as soon as possible, because the patient can deteriorate very fast. And here are the links related to my presentation, and I hope that you enjoyed it. I wish to you all the best, and thank you.